we got up that early, and we'll start right away, warming up what we've done yesterday, the fast exam, and waking you up will be Julia Sheffield, a junior doctor from Stockholm, and well, let's go, Julia. Thank you for coming here. Well, no worries.
Interpret them for you, but I do want you to interpret them while we go through them, because there might be a question about them at the end. There will also be some questions throughout the presentation, which you can access through Feedbacker, and the link is at the top right of the screen. So do please log on to that one. The questions will pop up as I ask them. Right. We're going to fast forward a couple of years, and you are now a qualified doctor working within your respective fields. Feels pretty good. For one reason or another, you've ended up doing a rota in the emergency department. It's a week of night shifts, and this night, the fourth night in a row, has been a good one. You've seen about a patient an hour, and you've had time to have your 2, 5, 10 cups of coffee, whatever you feel comfortable with. You're currently sipping a cup now with your feet up. Your pager goes off. The ambulance is bringing in a 30-year-old man who has crashed with his motorbike on his way to work. He's mobilized by the ambulance crew, but the drive is pretty short, so they haven't really had time to do that much. They've noticed that he has a high breathing frequency, a high pulse, but a fairly stable blood pressure. So, he comes into your ED, you introduce yourself, and you find out that the patient's name is Jonathan. He's 30 years old, as said before, and he skidded off the road with his motorbike in approximately 70 kilometers per hour. He was wearing a helmet and full protective gear, and he's been awake the entire time. He complains of pain on his right side, which is where he landed. But apart from that, he seems to be fairly okay. You listen to Jonathan's voice, and it's strong and clear, and you look in his mouth, and you don't see any teeth or anything else that might potentially obstruct the airway, and you determine that A is clear, I'll move on to B. You put your hands on Jonathan's chest wall, and you notice that the breathing patterns are symmetrical. The thorax wall is moving well, but the breathing frequency is quite fast, 22 per minute. Upon auscultation, you note symmetrical breathing movement, breathing sounds, and the percussion tone is also symmetrical and normal. He's saturating 94%, and you think that, oh, well, 22 breaths per minute, 94%, maybe I'll give him some oxygen. But then you're happy with B, and you move on to C. You look at the patient, and he's quite pale, and his skin feels cool. His radial pulses are very weak, but very fast. You count it to 125 beats per minute. The capillary refill time is slightly prolonged, with 4 seconds, and you ask for a blood pressure, which is 95/55. You scratch your head, and you think, okay, so this patient who's been in a crash has a high pulse and a low blood pressure, with a high breathing frequency and a prolonged capillary refill time. Maybe he's bleeding somewhere. You seem to have a C problem. Thankfully, in your youth, when you were still young and dashingly handsome, you attended a summer school for ultrasound in Graz, back in 2016. And you remember that they taught you something about a FAST protocol, maybe even eFAST. And you think that maybe this could help me with my diagnosis. You think that the eFAST protocol is probably good because he's hit his thorax wall, so there might still be a problem with the lungs. And following the ATLS concept, you start scanning the lungs. And this is what you see when you put your probe on the highest part of the thorax wall on the right side. Yeah, you feel fairly happy with that image, and you move on to the highest part of the thorax on the left side. You think back to what you were taught, and you think that maybe there's something that could be confusing in this image. And this brings us to the first question. When can you expect a false positive result when scanning for a pneumothorax? And you can answer this on Feedbacker via your mobile phones. You can also, that's the question that you see there? No, that's not the question that you see there. The question before, please. Up. That's the one. But now you've seen a preview of the next question. So, is it when you have multiple B lines, when the patient has had a pleurodesis, when you can see a lung pulse, or when you're using the linear probe? I'll give you a couple seconds just to contemplate that. All right. The answer is, of course, the second, when the patient has had a pleurodesis. So when the patient has had a chemical adhesion of the pleural sheaths so that they don't actually slide against each other, then you also won't be able to see that sliding in ultrasound, and it will look like the patient has a pneumothorax, regardless of if he or she has or hasn't. Okay, you've contemplated this and you think, okay, I'm going to move on with my scan and look at the heart. Okay, fairly pleased with that image too. And the next thing we're going to scan is obviously the abdomen, where we are more likely than anywhere, I guess, to see free fluid. Which moves us on to the next question, which you've already seen. How many milliliters of free fluid is the minimum that you can expect to detect if you're good at doing the fast ultrasound? 1, 2, 4, or 500 milliliters? All right, we're going to stop it there. Yes, 100 milliliters is correct if you are a good scanner. Sources vary slightly on this, and you've here heard everything from 100 to 250, but there's also some sources claiming that 400 is sort of the limit for when you can always expect to be able to find it. When scanning the abdomen, you think about the patient's symptoms. He'd crashed and landed on his right, so you probably want to start with scanning the right side. What I like to do when scanning the right side is I like to feel the edge of the ribs. And I put my fingers, and about 3 fingers up in the mid-axillary line, I put my probe. And on most people, this will get you a view of the kidney and the liver. And that's what you do, and this is what you see. Okay. You think about that for a little bit, and then you move on to the left side. You remember that the left side is slightly more difficult than the right side, and you think it was a little bit further up and a little bit further back. So what I like to do for this scan is I once again feel the edge of the ribs. I put 4 fingers, and then I put my scanner above my 4 fingers in the posterior axillary line. It doesn't always get me the kidney, but I usually see enough to be able to orient myself to find it. So that's what you do, and this is what you see. No, that's not what you see. We have a question first.
Well, about the questions, I'm sorry to interrupt you shortly. We'll just quickly explain what feedback is and what you can do with it. Just take out your smartphones. Anyone who got a smartphone, please take it out. And you can all vote for those questions. So we'll get live feedback from all of you, what you think. And it won't be personalized, so no worries if you're not sure. And the URL you should go to is fbr dot
If you go to the
io,
and you have the link
and
just
it's
up
up there. It's fbr.io afdzs. And as soon as you've joined the session, you can vote, and I'm pretty sure we'll have some super nice results soon. Thank you so much.
Yeah.
Maybe give it a second for everyone
Yeah,
to
definitely.
vote. Thank you so
thanks.
much.
And thank you for the people who managed to find it on their own. All right, how are people doing? All set? The address up once more?
Everybody got the address? Okay, perfect.
Excellent. So, my next question. We scanned the right side, right? But as we were doing an EFAST, there's something kind of missing in the scan that we looked at. And what is it that is missing? Is it the liver, the kidney, a full scan through of the organs, or did we miss the diaphragm? All right. Everyone feeling done with that? So, what we missed was we didn't look at the diaphragm in this. And why we look at the diaphragm is, of course, because we want to see if there's blood beneath the diaphragm to show that there is free fluid in the abdomen, or if we have free fluid in the pleural space, so above the diaphragm. And now we're moving on to the left side. And this is the first scan through that you do. And you think, okay, well, I've now located the spleen and the kidney, and I've scanned through it, and I'm not going to miss what I missed on the other side when doing an EFAST. So, also going to look at the diaphragm. And stepping outside again of the patient case, we're going to contemplate what to do when a patient where you've done an EFAST that was negative becomes suddenly unstable. Would you call for backup? Would you redo your scan? Would you send the patient for a CT, or do you order a new hemoglobin value? All right, you guys feeling done? Well, for this, I would like to say that calling for backup is always the correct answer. Always the correct answer when in doubt. I would call for backup in this patient that is circulatory unstable with a potential bleeding. You can also redo the EFAST, but you might redo it while waiting for the backup to arrive. The last scan we do is of the pelvis. And I usually start with a transverse view. I'll put my probe slightly higher than the pubic bone, and then I will slide down to see where I find the bladder, and also to give the patient a little bit more integrity. And when doing that, this is what you see. You scratch your head and go, okay, well, I'll do the last scan as well, which is the transverse view. No, not the transverse view, the sagittal view. So you turn your probe with the marker to the patient's head, and you see this. Now, you've completed your eFast scan. And what is your interpretation of the scan? What would you say to your colleagues about the scan that you just did? Did you find no pneumothorax, but free fluid in the hepatorenal recess? Did you find no pneumothorax and no free fluid in the abdomen? So a completely normal scan. Did you find a pneumothorax on the right side and free fluid in the hepatorenal recess? Or did you find that there was no pneumothorax, but there was free fluid in the hepatorenal recess and in the small pelvis? All right, you guys feeling done? Well done. There was no pneumothorax because we could see lung sliding on both sides. There was some free fluid just between the kidney and the liver, so in the hepatorenal recess. There was also quite a bit of fluid in the small pelvis, just behind the bladder. Now, if we think back to Jonathan, our patient, with this scan in mind, so a positive fast with free fluid in the abdomen, he has a high pulse, a low blood pressure, high breathing frequency, and a prolonged capillary refill time. What would you do after obtaining this scan? Is the patient fine? There's no need to do anything. Do you send the patient for a CT? Do you consult your surgeon colleague and plan for an emergency operation, or do you plan for a potential massive transfusion with whole blood, so red blood cells, white blood cells, and platelets? All right. 2 correct answers again. Asking for help, as I said, is always the right answer, and in this case, the patient is most definitely going to need an operation. So consulting the surgeon and planning for an emergency operation is a good idea. You also have a patient who is clinically not completely stable and who has probably bled out quite a bit. So planning for a massive transfusion is also a good idea. Now, the patient goes to surgery. He's shown to have a liver laceration. The bleeding stopped, and he receives 5 units of blood. He stays at the hospital for a while, but then he's discharged, and thanks to your stunningly beautiful handling of the patient and what you learned here about using ultrasound as part of your diagnosis and clinical evaluation and putting them together, he is now doing fine. Jonathan is, of course, not a real patient, but he is a real person who I work with, and I would just want to take a moment to thank him for letting me scan him, being the patient in the video that you saw before, and also providing me with the positive, fast images. So thank you, Jonathan, and thank you all for listening. I hope you learned something more.
Thanks a lot for your talk, Julia. It was really good. One more thing, are there any questions? I'm sorry, it took a bit. Are there any questions about the talk? Well, thank you so much. And we'll continue in about 5 minutes. We'll need to do some time for the setup. we won't do a full break. I don't think you need a break after such a, well, refreshing 15 minutes or 20 minutes. So just give us 5 minutes for the setup of the next lecture, and we'll be back with another amazing lecture.